This lecture is a lecture on prostate cancer. This is part of the Year for Oncology Clinical Attachment. My name is Dr. Christina Mapagu. I'm a lecturer in oncology from the Blacktown Mount Druitt Clinical School. Learning objectives of this lecture. We'll be looking at the epidemiology of prostate cancer. Also be discussing and reviewing the risk factors for developing prostate cancer. I will be briefly discussing the relevant anatomy of the prostate. We'll then look at the clinical presentation of prostate cancer and the process involved in its diagnosis, including the staging. We'll look at the pathology, such as histology and grading of prostate cancer, and different treatment options. Finally, I will briefly touch on the issue of screening in prostate cancer. Now, with the exception of the non-melanoma skin cancers, prostate cancer is the most commonly diagnosed cancer in Australia. It is the fourth leading cause of death among Australian men after heart disease, lung cancer, and cerebrovascular disease. In 2011, more than 3,200 deaths in males were from prostate cancer, and it is the second most common cause of cancer death in men, second only to lung cancer. There are more than 20,000 new cases diagnosed each year, and the incidence appears to be increasing. It is estimated that the incidence of prostate cancer will go up to about 25,000 in 2020. This increase in incidence are likely due to increased presentation for testing, and with the GPs doing more and more of the PSA tests. There's also changes in the diagnostic practices and also the increasing aging population. What we do know is survival for prostate cancer is high in comparison to all the other cancers. Between 2006 to 2010, 92% of men diagnosed with prostate cancer is alive at 5 years after diagnosis. This survival rate has improved over the years from about 59% in 1986 to a 5-year survival of 90% in 2007. So prostate cancer patients are doing better, and it's likely due to a combination of early diagnosis and better treatment. With regards to risk factors, increasing age is by far the most important risk factor for the development of prostate cancer. In 2010, more than 79% of prostate cancer cases were diagnosed in men aged 60 and over. About 1 in 5 Australian men will likely be diagnosed with prostate cancer by the age of 85. And studies of age-specific incidence reveals that prostate cancer risks begins to rise sharply after the age of 55 years, and it peaks at the ages of 70 to 74. Family history and genetics is another risk factor for prostate cancer. We do know that a man who has one first-degree relative with prostate cancer has a greater than twofold increase in risk in developing the disease. And if he has two first-degree relatives, for example, a father and a brother, this risk then increases to almost more than 4 times. Although the actual genes for this are not entirely known, some known cancer genes has been associated with increased risk of prostate cancer. For example, the BRCA2 gene mutation increases the risk of developing prostate cancer in men by more than 3-fold, and men who has the BRCA2 gene mutation often develop prostate cancer at a younger age. The genes involved in the Lynch syndrome, that is the HNPCC genes, has also been associated with increased prostate cancer risk. Ethnicity or race is also known to be a risk factor. Prostate cancer is most common in men from African descent in comparison to Caucasian men. In contrast, Asian men has a lower prevalence of prostate cancer compared to other races. So just a brief discussion on the anatomy. The prostate lies below the bladder and surrounds the prostatic urethra. It is surrounded by a capsule and is separated from the rectum by a layer of fascia. So where it's situated and the structures that it surrounds it, it's easy to understand the symptoms that people present with when they develop prostate cancer. Another thing also to note in terms of the anatomy is that there's neurovascular bundles that lies on either side of the prostate on the rectum. This neurovascular bundle is derived from the pelvic plexus and has an important role for erectile function. So one can then see why definitive treatment to the prostate, such as a prostatectomy or radiotherapy to the prostate, one of its major complications is the development of erectile dysfunction. This is because of the close relationship of the neurovascular bundle to the prostate. Looking at the prostate itself, it can be divided to a number of regions or anatomic zones. The largest zone in the prostate is called the peripheral zone. This extends posterolaterally around the gland from the apex to the base of the prostate. It is the most common site where prostate carcinomas develop. In fact, 70% of prostate cancers develop in the peripheral zone. Then there's the central zone, which surrounds the ejaculatory duct apparatus and makes up majority of the prostatic base. 15 to 20% of the cancers arise from the central zone. Finally, there's the transitional zone, which constitutes two small lobules that sits next to the prostatic urethra. About 10 to 15% of the prostate cancers arise from the transitional zone. Also, this is the region where benign prostatic hyperplasia originates from. How does prostate cancer present? Men with prostate cancer present in different ways, and their method of presentation usually can be related to the extent of the disease. Some men present with asymptomatic disease, and the prostate cancer is detected as a result of an increased PSA on blood tests. With many more doctors and family GPs doing a PSA blood test as a routine test, even in men with no symptoms. This is managed to pick up prostate cancer in more recent years. So about 47% of men are diagnosed with prostate cancer without any symptoms. Some men can present with symptoms related to localized disease. These symptoms usually involve hematuria, urinary frequency, urinary urgency, and decreased urinary stream. As one can see, these symptoms are not particularly specific for prostate cancer presentation. So one really needs to also think about potential differential diagnosis in patients who present in this way. Yes, one needs to think about prostate cancer. However, other things to consider also and rule out are things like benign prostatic hyperplasia, prostatic calculi can also present in a similar manner, prostatic cysts, and prostatitis. Finally, men with advanced disease can present with symptoms suggestive of systemic involvement or metastatic symptoms. These men can present with weight loss and anorexia. They can also present with bone pain secondary to bony metastases with or without pathological fractures. Some men can also present with lower extremity pain and edema. This is usually related to involvement of the pelvic lymph nodes, resulting to obstruction of the lymphatic return from the lower limbs. And finally, men can present with uremic symptoms secondary to renal failure as a result of obstructive uropathy. In terms of clinical evaluation of someone who has prostate cancer, we often do a triple assessment, which usually which constitutes a blood test, detection of a PSA, an elevated PSA on blood tests. One needs to examine the patient, so not only you do a general systemic examination, but also a digital rectal exam. And finally, you need a biopsy to confirm the presence of prostate cancer, so a prostatic biopsy. Following this, one then need to determine the extent of the disease involvement of the spread by staging them, and this is usually done by imaging using CT scans and bone scans. So briefly, in terms of prostatic specific antigen, or PSA, so this is a protein that's produced by the prostate gland, not produced by anything else, produced by prostate tissue. It is a sensitive test, but it's not particularly specific for prostate cancer. As a result, it's not a gold standard way of diagnosing prostate cancer, since it is increased by other reasons, not just prostate cancer. So PSAs can also be elevated in benign prostatic enlargement, if men has a UTI or prostatitis, that can lead to an increased PSA, and also recent instrumentation such as a cystoscopy or a catheterization that can also cause an elevated PSA. Now, because of the lack of specificity of the PSA, its role in screening or diagnosis is not, it's still controversial. However, in patients or in men who has a diagnosis of a prostate cancer, the monitoring of the PSA levels plays an important role in subsequent follow-up and treatment. So we use this in surveillance, in follow-up, in the detection of early biochemical relapse, or in monitoring response to treatment. In terms of the digital rectal exam, this must be done in all prostate cancer patients being considered for a prostatic biopsy. And the reason for doing this is not to diagnose the prostate cancer, but to help with the staging. So the T part of the staging, which I will talk about later, to determine how much of the prostate has cancer involved. So can you actually feel the presence of cancer? Is it involving only one lobe or both lobes? Does it extend to the surrounding structures of the prostate? In terms of the pathology of prostate cancer, really adenocarcinoma is by far the most common histology. So 95% of prostate cancer is almost always adenocarcinoma. The rest are, again, not very common, but can happen. So there's the urothelial cancer, the transitional cell cancers. This is similar to the other urothelial cancers, such as the bladder cancers, that they can also arise from the prostate. You can also develop a squamous prostate cancer or an adenomyocystic prostate cancer. There's also the neuroendocrine types, such as small cell or the non-small cell. Leiomyosarcomas or rhabdomyosarcomas can originate from the prostate, as does carcinosarcomas. Some lymphomas can also originate from the prostate. One also needs to consider the possibility of metastases to the prostate, for example, from a lung primary, a melanoma primary, or a seminoma. So just looking at the image on the slide in the left side, this is an example of a prostate adenocarcinoma. The area in the left upper corner. That glandular structure, that's what a normal prostate should look like, many of those glands. However, the rest of that image just shows loss of that glandular structure. The architecture of a normal prostate is lost, and all you get are just little nests of tumor tissues throughout, surrounded by stroma. And that's the cancer. In terms of grading, so we need to grade cancers to determine how aggressive or fast growing they are. And in prostate cancer, we use a specific type of grading called the Gleason score, which is essentially the two most common patterns that is seen on histology. The patterns is a scale called the Gleason pattern scale, which is ranges from 1 to 5. So Gleason grade 1, it's usually sort of your normal, very much like a normal prostatic tissue, with your small uniform glands that are very tightly abut each other. Then you have grade 2, where you still have those small uniform glands, however there seems to be more stroma and more space between glands and not as tightly, closely packed in together. Gleason grade 3 is when you have more irregular sized glands, different sizes, different shapes. They tend to be more widely dispersed. You also get infiltration of cells from the glands at the margins. So that's when you're starting to lose the normal architecture of the prostate. Grade 4 is when you have fused glands that are just, forming into coarser chains and infiltrating masses of cancer cells. And finally, grade 5 is when you have, you've completely lost the glandular differentiation. It looks nothing like a normal prostate. There are cells infiltrating the stroma, sheets of cells or nests of cells, and you also get large cells with atypia and pleomorphism. So depending on these patterns or grade, you get the two most common pattern and grade, come up with a Gleason score. And the Gleason score helps us determine how, whether it's a high grade or a low grade cancer. So a Gleason score of 6 and less is what we would consider a low score, and it indicates a slow growing, less aggressive cancer. A Gleason score of 7 would be sort of what we would call an intermediate score, and it indicates a faster growing or moderately aggressive cancer. And a Gleason score of 8 and above is what we'll call a high score, and this indicates a fast growing, very aggressive cancer. Now, in terms of staging, as with all the other tumor types, so staging for prostate cancer does use the standard TNM staging, but in addition to this, we would normally combine this with the Gleason score and also PSA to come up with clinically relevant staging. So with regards to the TNM staging, T1 is when you have clinically inapparent tumor, so tumor that can't be palpated on examination or not seen on imaging, so no obvious tumor. T2 is when you have tumor confined within the prostates, so the tumor can be found either in just one or both lobes, usually only found on needle biopsy. It's usually not palpable and sometimes not really seen on imaging. A T3 tumor is tumor that extends through the prostatic capsule and invades into the seminal vesicle. These tumors sometimes you're able to feel on digital rectal exam, depending on which part of the prostate is involved. Finally, T4 is when you have either a fixed tumor or a tumor that invades the structures adjacent to the prostate, other than the seminal vesicle, so it's the bladder, the muscles, and also the pelvic wall. So, and N obviously is the regional lymph node, whether that's involved or not, and M is the presence of metastases. So combining the TNM stages with Gleason score and PSA, then we can come up with the the clinically relevant stages. So stage 1 is when you have tumor confined in the prostate with a low PSA, no lymph nodes, and low Gleason score. Stage 2 is again tumor that's confined in the prostate, no nodal involvement. Whether they're 2A or 2B depends on the level of the PSA, or whether it's a high, intermediate, or low Gleason score. Stage 3 tumors are the ones that has a T3 tumor, so tumor that extends through the prostatic capsule regardless of the PSA or the Gleason score. And finally, stage 4 is when you have involvement of adjacent organ structures or distant organ structures, or the presence of lymph node involvement. So that's actually very complicated and very difficult to remember. So really, in terms of clinically, it's probably best to think of stages of prostate cancer into 3 different groups. So there's a localized, locally advanced, and advanced stage prostate cancer. So localized prostate cancer is what we would normally consider stage 1 and 2 in the previous slide. So this is cancer confined within the prostate. There's a locally advanced prostate cancer, which is what we would consider stage 3. So cancer that extends clinically beyond the prostatic capsule, invading the pericapsular tissue, the bladder neck, or the seminal vesicles. And finally, there's the advanced stage, or the stage 4 prostate cancer, where there's evidence of metastatic spread, either to the lymph nodes or the other organs. So why do we bother staging our patients? The reason why we do this is staging them allows us to help not only prognosticate, but also to determine the type of treatments that can be offered. So this slide just summarizes the approach. We need to determine what the stage is, and depending on the stage, then we can determine what kind of treatment options we are able to offer. So we'll go through that a bit more, but use different patient cases to illustrate this point. So the first case that we'll look at is an example of a localized prostate cancer. So that's diagnosed on a routine PSA test. So we've got a 70-year-old male who presents with an elevated PSA on routine testing. He didn't have any symptoms whatsoever. It was just a blood test that his GP decided to do. Because of the elevated PSA, a digital rectal exam was performed, and it was a large prostate. However, it was smooth. There was no evidence of cancer on digital rectal exam. However, because of his age, the elevated PSA, and the enlarged prostate, he was referred to a urologist for a prostatic biopsy. And biopsy confirms the presence of adenocarcinoma with a Gleason score of 6. And if you remember, Gleason score of 6 is what we would consider a low-grade or low-risk tumor. Staging imaging with a CT and a bone scan shows no evidence of metastatic disease. So in terms of what are his treatment options that we have are active surveillance, surgery, or radiotherapy. So what are the treatment options in localized disease? So there's a few things that we could offer. So the first thing is active surveillance. So active surveillance is only offered in a specific group of patients, and this is when we do not necessarily offer definitive treatment to prostate cancer. Instead, we perform very close follow-up of the patients and then offer definitive treatment depending on the progression of the disease. Now, the reason for this is to try and avoid unnecessary treatment in patients that may have indolent disease and treat only patients with symptoms or signs of a more aggressive or progressive disease. Again, it's only a specific group of people that you would offer active surveillance for, so usually people who has asymptomatic disease, such as a man who was detected to have prostate cancer from a PSA test, also a low-risk tumor, so a low PSA, a T1, T2 tumor with a low Gleason score. So these are the type of patients that you would consider offering active surveillance in. And what's involved with active surveillance? So usually involves 3 monthly PSA testing, 6 monthly digital rectal examination, and depending on the results of these, perhaps a repeat biopsy and maybe a MRI scanning. Other more definitive treatment options, surgery, so removal of the prostate and maybe some lymph node removal to look for the extent. So usually done as a radical prostatectomy, so the whole of the prostate is removed. Sometimes this is done laparoscopically or with assistance of a robot. Radiotherapy is another option for the definitive treatment, so either brachytherapy, where you have radioactive beads implanted into the prostate, or your more traditional external beam radiation therapy. So why would you offer radiotherapy over surgery? Consider these in perhaps patients who are not quite fit enough to have a radical prostatectomy, or in patients whose cancer might be involving particular structures that would preclude the surgeon from taking the prostate out with a good clear margins. So in these cases, radiotherapy can be given as primary treatment. Other roles of radiotherapy in the treatment of prostate cancer is in salvage radiotherapy, which I will talk about a bit later, and also in palliative radiotherapy for localized symptoms. So the next case is an example of a locally advanced prostate cancer presentation. So we have a 60-year-old male with a 2-month history of urinary symptoms, urinary frequency and urgency. His blood test shows that his PSA was elevated at 19. He had a palpable prostate on digital rectal exam. However, the prostate was still smooth despite being enlarged. He was referred to a urologist for a biopsy, which confirms the presence of adenocarcinoma with a Gleason score of 9. So again, if you remember, Gleason score of 9 is what we would consider a high-grade tumor. Staging CT scan shows no evidence of distant metastases. However, there was extracapsular extension of the tumor in the prostate. So in this man, what are the treatment options? So we would not offer him active surveillance, as he was obviously symptomatic, and he has a high-grade tumor. So really, he needs definitive treatments, either with surgery or radiotherapy. With surgery, sometimes we may give post-operative radiotherapy, and this can be done for a number of reasons. So one example would be following surgery, if there was evidence or suggestive that there might be residual tumor, so let's say involved margins, and the surgeons aren't able to resect, go back for another resection. Radiotherapy can be offered following surgery. Also, after prostatectomy, you would expect PSA levels to fall down to undetectable levels. If for some reason PSA levels doesn't fall down, or let's say it goes down for a little while and comes back up, this suggests that there are prostatic cells that remain, or prostatic cancer that remain, perhaps microscopic. Then you would usually offer salvage radiotherapy following this to try and catch whatever residual tumor that's left. And finally, radiation therapy plus or minus the presence of hormone therapy, or which is androgen deprivation therapy, can also be an option in locally advanced disease. So the brief note about tumor risk groups. So all the treatments that is given for patients that has localized or locally advanced cancer is really to try and aim to reduce and minimize the chance of recurrence following treatment. The chances of recurrence depend on certain parameters that can stratify them to being either low risk, intermediate risk, or high risk. So the low risk tumors are the ones that are confined to the prostate, so T1, T2 tumors. Often they present with a low PSA and a low Gleason score. So in this low risk group, they have a very good 5-year disease-free survival. So usually after 5 years, 85% of these men would be cancer-free. Then there's the intermediate risk, so men that has a slightly bit more extensive tumor, so those that has a T2B or C tumor, an elevated PSA or a Gleason score of 7, intermediate grade tumor, then their 5-year disease-free survival falls down to 50%. So that means half of the men with intermediate risk tumor will have their cancer recur by 5 years. And finally, there's the high-risk tumor group. So those are the ones that have tumors extending beyond the capsule, or tumors that has high PSA or high Gleason score. So in this group of patients, 2/3 of them will have their cancer recur after 5 years. The next case we'll look at is that of a first presentation with metastatic disease, and most of these men obviously have never had hormone treatment and would be considered hormone naive. So we have Mr. AS, who's a 60-year-old man who presents with a 4-week history of back and left shoulder pain. His GP, among other things, did a PSA and found that it was elevated at 40. He had a digital rectal exam which shows an enlarged prostate with evidence of some cancer on examination. He had staging scans which shows that he has obvious tumor in the prostate, but also that he has metastases in the L4, L5 spine and also his left shoulder. So although he hasn't had a biopsy confirming the presence of a prostate cancer, the presentation with bony metastases, an elevated PSA and also a tumor in the prostate, that would often be enough for us to consider that he does have metastatic prostate cancer, and enough for us to offer him treatment for prostate cancer without a biopsy. However, in saying that, if there's at all any doubt with the diagnosis, then you must do a prostatic biopsy. And in some cases with clinical trials, often need a tissue diagnosis, then in those cases you would also consider doing a prostate biopsy. So we have hormone-naive metastatic prostate cancer. So what are his treatment options? So his main treatment options at this point would be androgen deprivation therapy. They also consider giving him bisphosphonates, and I'll talk about that a bit later. And one may also consider giving him radiotherapy depending on how he responds to the systemic treatment. So continuing on the case, Mr. AS was commenced on androgen deprivation therapy with goserelin, which is a luteinizing hormone-releasing hormone agonist. And he had very good response to the ADT. His PSA fell to undetectable levels, and his bony pain was very much improved and did not need any radiotherapy. However, 3 years later, Mr. AS developed increasing pain in his left shoulder and spine, which is not really being controlled by increasing analgesia. His PSA has been rising over the last 3 months, and a restaging CT scan have shown that he has increasing lymph node masses and also lungs that potentially has metastatic lesions. So in summary, this man now has developed castrate-resistant prostate cancer, so he's no longer responding to androgen deprivation therapy alone. And in this setting, his options for treatment are commencing chemotherapy for systemic treatment. This has disease that's progressing despite androgen deprivation therapy. And also one would consider giving him radiotherapy for his increasing pain. So treatment options in advanced prostate cancer. So we'll look at two forms of systemic cancer therapy. So there's androgen deprivation therapy and chemotherapy. So we know that prostate cancer is very sensitive to the growth effects of androgens or testosterone. So the aim then is to try and starve the prostate by blocking the action of testosterone or reducing the amount of testosterone produced in the body. How do we do this? There are different approaches. So there's the LH-RH agonist, or the gonadotropin-releasing hormone agonist. There are also anti-testosterone, such as the bicalutamide. And I'll briefly touch on abiraterone, which is a new oral androgen synthesis inhibitor. It acts on CYP17, which is an enzyme that plays a role in the production of testosterone. And I will briefly go through that. So that's a form of androgen deprivation therapy. In patients who become resistant to the effects of androgen deprivation therapy, so when the tumor becomes castrate resistant, then chemotherapy is the main treatment option for systemic disease, and chemotherapy is often taxane based. I put bisphosphonate there as a form of systemic therapy, but it's not used because it has any effect on the cancer growth at all. What it's useful for is bisphosphonate, particularly zoledronic acid, has been shown to reduce the skeletal related events. So it's really only for patients that has metastatic disease to the bone, and zoledronic acid or bisphosphonates help reduce the possibility of pathological fractures or increasing pain as a result of the metastasis to the bone. Other treatment options that's available for patients who has advanced prostate cancer. So one option that I placed there is what we call watchful waiting. So like similar to active surveillance, this is only really offered to a very particular group of patients. So this is when we don't necessarily offer any particular treatment, and what it usually involves is regular follow-up with the PSA tests and clinical checkups, and offer symptomatic treatments when the need arises. Watchful waiting really is only offered to patients who has incurable stage disease, so stage 4 advanced disease, those whose life expectancy is short, and those who often patients who hasn't had any surgery or radiotherapy. And finally, palliative radiotherapy is an option for symptoms, localized symptoms such as bony metastases. So briefly on androgen deprivation therapy, as I said, prostate cancer needs testosterone to grow, and the aim obviously of androgen deprivation therapy is to starve it from the growth effects of testosterone. So normally the hypothalamus produces GnRH, gonadotropin releasing hormones, which acts on the GnRH receptors on the pituitary gland, which then triggers it to produce luteinizing hormones, or follicle stimulating hormone FSH, which then acts on the respective receptors on the testes to produce testosterone, particularly via LH-LHR interaction. So how can we stop the production of testosterone? one can use a GnRH analog or a GnRH antagonist. So a GnRH antagonist is one that blocks the receptor. However, one can ask, why would you have a GnRH analog? Because they tend to stimulate the effect of gonadotropin-releasing hormone receptors. So a GnRH analog such as goserelin, which we often use in prostate cancer. So usually when GnRH stimulates the pituitary to release hormones, GnRH is usually released in a pulsatile manner. However, if there is continuous stimulation of the pituitary, this leads to GnRH receptors in the pituitary to be downregulated, effectively turning off the production and release of luteinizing hormones, and therefore turning off the production of testosterone. So when we give goserelin to our patients, they provide the continuous stimulation leading to downregulation of the GnRH receptors in the pituitary. Finally, antitestosterone is then used, can be used, and it acts by blocking the action of testosterone on the androgen receptors. So briefly, androgen biosynthesis, this slide is a bit complicated, but it looks at how testosterone is produced. So the ACTH stimulates the adrenal glands to produce the precursors to testosterone. So pregnenolone is then converted eventually to DHEA by the action of these two enzymes, which both called CYP17A enzymes. Production of DHEA then leads to the production of testosterone. I mentioned this drug called abiraterone previously. It's an oral tablet, and it inhibits the production of androgen by inhibiting the action of the CYP17A enzymes. By turning off these two enzymes, pregnenolone is no longer converted to DHEA, hence reduction in the production of testosterone, and that's how abiraterone works. All the other pathways would explain the side effects that people can get from abiraterone, but it's beyond the scope of this lecture. But if you're interested, just look up the source. I see it on the slide. And finally, on screening. Screening for prostate cancer really at the moment is controversial. There's no good test for general population screening. However, many people are doing PSA blood test plus or minus a digital rectal exam. Fortunately, there's still no clear guidelines as to whether screening should be done or who it needs to be done with. And what's really important is one needs to discuss with the patient the positives and the negatives of screening. We do believe that it is reasonable that in men over 60 who are more likely to develop prostate cancer, those who are expected to have a longer lifespan, again, greater possibility of developing prostate cancer, and those who are interested to have an assessment, then it's not unreasonable to do the test to screen for prostate cancer in these men. Similarly, in men who has a higher risk than normal for developing prostate cancer, so those that has one or more first-degree relatives diagnosed with prostate cancer under the age of 65, and men with a first-degree relative with a familial breast cancer or BRCA2 gene mutation, because these men are more likely to develop prostate cancer compared to the general population. There's particularly certain groups, so you can target particular groups of patients for screening, but in terms of population-wide screening for prostate cancer, the jury is still out. So to summarize, prostate cancer is a very common cancer. and it's responsible for a high burden of disease. However, survival rates still remain to be higher than most other cancers. In terms of diagnosing prostate cancer, there's a triple assessment approach with a PSA, digital rectal exam, and also a biopsy that really needs to be done before staging. In terms of treatment options, there are different treatment options that are available, and how or what treatment options we offer will depend on a number of things, such as the stage, whether it's localized or advanced, and also we will consider things like life expectancy, patient comorbidities, and also patient choices. So in this lecture, we covered both the epidemiology and risk factors of prostate cancer. We looked briefly on the anatomy. We made a discussion about the different clinical presentations, the diagnosis and staging process, the pathology and the grading, what the different treatment options are for the different stages, and briefly on the screening for prostate cancer. If you have any questions regarding the content of this lecture, please feel free to email, and I'll aim to reply back in a timely manner. Thank you.